Now to introduce you to Dr Andrew Fraser, who is Director of Public Health Sciences, NHS Health Scotland. He was Director of Public Health in NHS Highland in the 90s, then Deputy Chief Medical Officer in the Health Department for the Scottish Office, then the Scottish Executive in the early years of devolution. As Senior Advisor on Public Health Policy, he took a particular interest in health protection matters, alcohol policy, public health laws, and increasingly on health inequalities and the health of marginalised groups. And he's going to talk to us today about the essential relationship between addressing health inequality through a Healthy Homes initiative. Thank you.
Thank you very much indeed. Good morning, everybody. It's very good to be here. This is a very serious subject, and I'm going to not going to beat about the bush and get into the material I've got, but we are encountering, and people in the housing sector will be very familiar with the headwinds that people they serve are encountering, and health, likewise, health and housing are very closely associated in this respect. Tackling housing and homelessness is something that the health sector is engaged with, and we need to deepen that joint interest, engagement, and deepen our commitment to improve matters for people with housing difficulties and who are experiencing homelessness. But tackling these is pivotal to tackling inequalities, and specifically health inequalities. The two are very closely interlinked. Here we go. I'm going to cover these headings, a bit about inequalities and a rapid course in epidemiology for those of you not familiar with the subject. And then we go into what we know about health and housing, which is limited. And then a bit about health of marginalised groups, because I don't think we can look at housing and health in isolation. And then what we are starting to understand, and I emphasize starting to understand about what we do about this. First, what do we mean by health inequalities? And here's the briefest of definitions and explanations what it is. I just point you to 3 or 4 phrases in this slide. First, unfair. The word unfair is in there twice. Inequalities is not created or does not arise by random or by chance. Things happen which create these inequalities. It is not a matter of active choice. They are not inevitable. We can do something about inequalities. We don't live with them with no prospect of making a difference. And the other thing to really underline and score what Graham has just said, this has got to be person-centred. It's got to be with the involvement of the people concerned. And people like myself and professional groups I represent need to snap out of this idea that we're doing good things to people. We're doing them for them, with them. And we've got to constantly remind ourselves about this. This is taken from the front page of the Poverty Truth Commission report of 2009. Are inequalities narrowing in Scotland? Well, here's a graph of things not getting better. If the line goes up, it's a bad thing. But these lines are just failing to come down. Straight, almost flat lines of us really making no inroads into narrowing health inequalities. The top line is about all ages, the bottom line and the right-hand side of the graph is about young people in younger ages. But the message here is that we are not making inroads into tackling inequalities. And a further graph about relative inequalities shows the paler line on the right-hand side, the young people up to 44 years old. The distribution of their mortality, which is, I suppose, the end point of inequalities. I mean, all sorts of bad things happen, but the thing about mortality is it's the worst thing that can happen to you, and it usually happens once, as far as I'm aware. And what it explains to us is that inequalities amongst younger people is even wider than inequalities amongst the general population. The lower line is about the under 75s as opposed to the under 44s. So our health inequalities narrowing in Scotland doesn't look like it. We've got to do more, got to do something different. And that's the international picture. What we've got there is life expectancy. The good news is that life expectancy is lengthening. I mean, since I was born, at least 10 years increase in life expectancy. The achievements of the 20th century in Western Europe, particularly Western Europe and the Western world, have been immense in terms of average life expectancy. But what we're seeing there, and I don't know if you can see it very clearly, is two coloured lines. One is the US, United States, above Scotland, which is the lower line, and it shows really where we were in 1971 was in the middle of the pack, near the middle of the pack in terms of life expectancy, and we are steadily dropping towards the bottom. So even in terms of other people's experiences as nations of improvements in life expectancy, we on average aren't doing as well as we might. I'll just leave it at that and press on, if I can, press. Okay, here's a model, though, of health inequalities and what gives rise to them. On the right-hand side, as you see here, are the effects, the things I talk about and you talk about, drug, alcohol problems, cancer, and heart disease, and so on. These are the effects of inequalities which come along upstream. And these are individual experiences. And what I'm talking about here in the housing context is, what is your home? What is your house like? What is your experience of that? But alongside other things, such as the physical environment, your quality of your educational and learning, the outcomes of that, and services generally, health services, social services, and so on. And upstream of that, though, is the wider environmental influences. So for housing, that wouldn't just be the quality and the nature of your housing and the stability of your housing tenure, but it would be where your housing is, the housing standards which underpin the quality, the neighbourhood, the housing development, the macro investment, the wider environmental influences, along with the other wider environmental influences. And they all bear down on this end point of health inequalities. But you'll see from the final section is that health inequalities are born of inequalities, wider inequalities, and these fundamental causes and perhaps the headwinds which are facing us of the economy and opportunities for employment. All of these feed into housing and health experience, which has these eventual effects. This is a linear model. One thing gives rise to another, gives rise to another. I'm not necessarily saying one thing causes another, as we'll come to see. The picture is quite complex. But this is where we are. Inequalities give rise to health inequalities. Health inequalities are the reason to bear on them. They're not precious things in isolation. Housing and health go hand in hand, are fundamental experiences for us in going through life. So we talk about downstream, this is the line that's just appeared, and upstream. We seem to focus on the downstream, the drugs and the alcohol and all these problems, whereas we really need to row upstream and look at what is causing inequalities and trying to tackle them. Here's a rather busy graph, but what it demonstrates to you is the range of life expectancies by CPP area. On the left-hand side, unfortunately, as you would expect, and with the lowest average life expectancy is Glasgow, the city of Glasgow. On the right-hand side is leafy Eastern Bartonshire, is it? Yes, it is. Funnily enough, they're side by side. Eastern Bartonshire is next door to Glasgow. But the other point of this graph, and I'm not going to entertain you with what it's all about, it's the range is the best fifth of the city of Glasgow, for instance, compared with the least fortunate at the bottom of the life expectancy. But there are very large ranges in life expectancy, even within small areas. But the other point of this is, it's not a bad good. They have it, they don't have it. It's a gradient. Glasgow is in a particularly unfortunate position, along with Central Scotland and Dundee, if you could see the titles and the x-axis. But they're not alone, and it's not as if they're the only ones who are having problems. People who are in the least fortunate position in some other areas, and particularly cities, have big challenges to face. So we're looking at it at national level, at local level, but it's not an all or nothing thing, it's a gradient. And just to get health in context and housing in context, here's the person at the centre, the people at the centre. And out there in the built environment is housing. And all the way in between, activities, local economy, community and lifestyle. We live in various states of which housing is part, of which your health and healthcare is part. But it's a lot more complex than that. We have a life to live as individuals and communities, of which housing and health are two key elements. And I'll come back to that. So anyway, the next area I'm going to cover is this second of three sections. What do we know about health and housing, health and no housing, or in other words, homelessness? And a little bit about health of marginalised groups, because I don't think we want to look at housing homelessness and health consequences in isolation. First, those of you who are familiar in the housing sector will know some of these data. And this is a chart about the prevalence of poor housing characteristics. A tantalising figure, 3 down, houses too few rooms. And we've got to bear that in mind when people are talking about the bedroom taxes. I will come on to say very little about the person who follows us after the break is going to focus on welfare. But these are poor characteristics and the prevalence of poor characteristics in the National Housing Condition Survey. And these aren't good news, and they're really into the teens of prevalence about really quite severe poor characteristics of housing. Here's a slide comparing, on the first column of statistics, the most deprived areas as opposed to the rest of Scotland, the other 85%. And it's really about the neighbourhood, the green spaces around our homes, access to a garden at the top, all the way down to where there's the biggest difference, children having access to natural environment, wooded areas. There are very big differences in opportunities for, and this is quite child-focused, this one, but not entirely, for children to play, to enjoy green spaces, to get out in the open, and informal spaces. Very, very stark differences of them too. So there are inequalities in the housing nature, housing condition, but also the environments in which we live. Now, many of you will know and be familiar with the literature about housing and home and health. I've conflated this slightly, and apologies for that, with housing and homelessness, but for reasons of time, I've sort of put them together. We know, midway down this table, we know something about damp and respiratory diseases amongst people who occupy damp housing. But until quite recently, we really haven't widened our understanding of direct links between poor housing conditions and the health consequences. But there are these very clear associations between health and housing problems, psychological problems, particularly anxiety and stress. And in the area of homelessness, I think you focus down increasingly on addictions and also self-harm and worse. Physical problems, it's not just respiratory diseases, many systems and infectious diseases. But there's also the mother's health, quite a lot of evidence that there are poor outcomes from pregnancy in poor housing. That's very serious, because it's serious for the mother, but also the child she bears. And in children's health, we'll come to see a bit about that, but there is increasing evidence, not only to do with children's general physical health, but their propensity to get into trouble and have behaviour problems at the age of 5 if they experience poor housing on the way through at the early start of their lives. And social problems. Well, what do I mean by social problems? Here's some data from Go Well, which I'll come on to say a bit more about. This is a fascinating research study in Glasgow. And this is 2 little excerpts from an account of what people are experiencing in high-rise flats prior to the demolition, replacement, and their relocation and other regeneration area. The first is about smell and the social effects of the environment they cannot control. It's just like it's a really horrible stench that goes through everywhere, and it's embarrassing. That's a social effect on health. That has health effects. The second one is a mother talking about their young adult son and his reluctance to bring friends home. He's very embarrassed, man, because you felt like you felt, I don't really want to bring my mates up to my house. That's a social consequence, but it's also a health consequence, because health has social dimensions to it. So we don't forget them. Children's health, this is an awful statistic which I picked up from a colleague. More than 1 in 20 of children growing up live in a home with these characteristics, where people have worries about meeting their home bills, their energy bills. And energy, certainly, again in the Go Well literature, is an increasing problem. Energy cost worries. We've got to bear that in mind too, but I'm not going to go into much more detail there. But what about the most severe housing problems we have, which is not to have one at all? And this is the title of a recent report from England. It deals with England, published by Crisis UK last year. A very, very stark message about limited life expectancy, early death from the cohort they recognised as homeless. And this risk rises to ×2 for the young adult population, well, children, really, 15 to 24, to ×4 for the age group 35 to 44. A rising level of mortality. And as I said to you before, mortality is the end point of all sorts of other, it's the worst thing that can happen to you, but just picture behind that the bad things that are happening that don't head up with death, about family breakdown, tension, and domestic violence and drug and alcohol problems. There's a picture behind that of intense stress, intense adversity, ending up for some paying the ultimate price. The highest numbers and risks are about drugs and alcohol and cardiovascular disease, 2/3 of deaths relating to that. And a huge fold difference, shall we say. Here's a graph about self-reported limiting long-term illness. And it's contrasting on the bottom line, people in housing, which is the black line. And you can see, as you might expect, people who are young, aged 15 to 24, about 5% of them saying they've got a limited long-standing illness. And it rises slowly to middle age and then more quickly to retirement age, on the right-hand side, age 65 plus, where around about 50% of people are saying they've got a limited long-standing illness. You contrast that with the next line up, which is people who are hosted residents, or the hostel residents, hostel residents. They're complaining much more frequently of limited long-standing problems. If you contrast what they say about themselves aged 30 or thereabouts, they've got the same level of limited long-standing illness as people in a home aged 60, around 60, 30, 60. As Sally McIntyre, one of the great researchers in public health, has said, it's like having more miles on the clock if you're a person. And suddenly they're thrust into old age in terms of their need for repair for their health problems. And then the top line is homeless people, rough sleepers. And the ones aged 20 have the same level of long-standing illness as the ones who are in homes aged 60. And of course, when they get to the 30s, it says it's the same level of long-standing illness as those of retirement age who have a home. So we really are consigning people to very, very poor quality of health and well-being within a very short time. Again, English data. And just to show that the Scots have done their homework on this too, you're probably familiar with this. It's David Morrison's study of Glasgow, looking at those registered as homeless in 2000 and following them for 5 years. The statistics, I won't go into detail about them, the statistics are roughly the same. Vast multiples of increase in death rate. But also he looked further down the page about what comes first. Does housing cause these things? Do these things like drug and alcohol problems cause homelessness? What he's saying at the bottom, the added risk of being homeless and dying, having a problem and then becoming homeless multiplies your risk by 7 times for drugs, for chest-related conditions, etc. 3 and 2-fold. So being homeless puts a massive extra burden on you and your survival, risk of not surviving. On health of marginalised groups, what I want to point out here is that we've talked about housing and its very important relationship with health. But people who are homeless don't have just their homelessness to deal with. And here's a case in point, and it's the only slide I have relating to welfare reform. I don't hope I'm not stealing anybody else's thunder. But what it's saying is that relating to the bedroom tax, which I've called the social size criteria, but I think there's other words for it, 82,500 households will be affected. Of them, 80% will have a disability, an adult with disability in the family. So their tenure is at risk, their welfare is at risk, their disability is a factor. Just three things, quite apart from all the other things that are happening in their lives, their relationships, their social well-being, etc., etc. And we need to look at that. I've quoted you earlier about the people with maybe too many rooms. Here's the prospect of new one-bedroom accommodation coming on the market to help us all as we downsize or are forced to downsize. It's not there. The scale of the response to what we need to do to adjust people's housing arrangements in response to this bedroom tax is puny, frankly. We've got to think further about that. I worked for a bit in prisons, and I cannot pass by the subject without raising it. And I'm very glad that Graham has raised it already on a number of occasions. When we talk about people with housing problems, we're not saying everybody's an offender. That's the first very important thing. Homelessness and offending has a substantial overlap, but they're not totally overlapping. 100% of homeless people are not 100% of offenders. But it's just to point out in this, in the second line down, that the risk of mortality for having been in prison for however long jumps, even compared to people who are drawn from deprived areas, which many of prisoners are. Their risk of dying is 2.3 times for men and 5.6 times for women. So if you add housing problems to disability, to welfare problems, and then you add prison, up it jumps again. The risk of coming to a bad end is higher still. The point in this is that we ask prisoners every couple of years now a whole range of things, and this is a question we ask them. I am worried. Do you agree with the statement that I am worried that alcohol or drug taking will be a problem for me when I get out? 3 types of prison. Barling's a local prison to Glasgow. Shotts is a long-term prison. Majority are lifers. Open prison, they're nearly there, nearly out. And they're saying a very, very large proportion will have a problem when they get out. And it's this transition from the controlled setting of prison to the completely uncontrolled setting of getting out, which is a very, very great concern to people who worry for their welfare and the welfare of the people who depend on them and who they're going back to. And the third slide and final slide relating to prisons is a study we've done linking prison to mortality and the number of people who die after coming out of prison. And what this graph shows is, in week 1, you've got a very, very substantial risk of dying. So you get out, you go to the pub, you lose all discriminant ability, you're offered a drug you don't know, and several more, and you maybe do harm to somebody or do harm to yourself. Your risk immediately on getting out of prison is huge. And the solution to that is to be there when they get out the gate. And I'm very glad to hear that Shelter is taking that issue increasingly seriously. It's the joins in services that we need to look at. The join between, in this area, prison and not prison. They've served their sentence, they're coming out. If the state put them in the prison in the first place, we have a responsibility for them when they come out. And we have a responsibility for people moving between services because we've created these joins. And I just make a plea to think of prisoners, wherever you're from, and their welfare when they get out, because they're under immense stress and incredible risk. When they get out, if they're met and they've steered past the pub, the 2 things they need to do in day 1 is go to the drug problem service and go to the housing agency. Because if day 1 goes by and these things don't get done, and they risk homelessness, they really are stymied. Anyway, back to the point, and the major issue here is that there are no proven strategies, but there are things we can do. Some things work and some things don't work, and we shouldn't waste our time on the things that don't work. Things that don't work, leaflets. It's fine to make people aware of things, but just to tell them what things are going on, or to tell them if you want to encourage them to take physical activity, there's a fitness club down the road that costs £300 a year. Not going to do it for health inequalities. There are things we should avoid and the things that are worth doing, and we'll come on to them. Again, a rather busy slide, but to summarise, we've looked at all the evidence. We know that up there in the fundamental causes, and this maps back to the lozenge slide I gave you earlier, fundamental causes are very important, but we can do things about individual experiences and wider environmental influences, and housing's in there. I don't have time to go into that any further. But action at several levels, not just the one, the housing issue, the health issue. Action at several levels simultaneously are most likely to work. So what are we starting to understand, and I'm very conscious of the time, Chair, about housing? And I'm going to come back to, well, first, we've got policies we've put to government about good places and better health, and the quote we've got here is turning hazards, or the discourse about hazards, into the discourse about opportunities. What is a good place to be in? What promotes your health and well-being? There's an agenda around that which we can push. Go Well, a very, very large research project which we in Health Scotland partly sponsor, but if you look at the detail, also some interesting bedfellows with us. The Glasgow Centre for Population Health leads it, but in there's Glasgow City Council, Glasgow Housing Association, Scottish Government, Greater Glasgow and Clyde Health Board. We're all in it, co-funding, co-supporting this. We all have an investment in learning from this research. And what does it tell us? Well, I'm just going to boil this down to what I think it tells us. And this is an example of about trying to answer the question about how do you promote people to encourage people to take more exercise. Well, it's nothing to do with Lycra or the gym or a club. It's to do with, I want to come out of a door, a place that I'm proud of, the smart, shiny front door. That's important. I want to walk along a place I feel safe. I want to go somewhere which is not just good, but very good. Iffy community facilities aren't of interest to people. Very good facilities are of interest. If you want to get somebody to walk and take a journey and take exercise and improve their physical activity, these are the neighbourhood, these are the housing issues that come up. What else does it tell us? And there's scattered issues in this little slide. Again, I don't know how easy it is to read, but what am I saying? Housing is not a guaranteed, or housing regeneration is not a guaranteed pathway to better health. Okay? The data tell us that they don't necessarily feel better when they move house. Their health behaviour doesn't necessarily change. They may say, oh, I'll give up smoking when I move to this bright, shiny new house. But they don't. That's what the data tells us. And they visit the doctor more. So it's not a passport to instant success. And should the NHS offer more? That's a question that I don't know the answer to. But critical times and joins are the theme I would point you back to. And then the other thing to place our research, and this is research about regeneration in health and context, are we involving people in the process of regeneration? And the nub of it is expectations are quite low of being involved. Were you involved? No. Well, I wouldn't expect to be involved. But what about the colour of your kitchen? Were you asked how you'd like your kitchen laid out and the colour of the units? No, I wouldn't expect to be. Well, you should expect to be. You should be involved in decisions that are important about your future house. But we have very low expectations of involvement in decisions about our own lives. And that's got to change. The final thing in this is regeneration isn't necessarily the most important thing that's happening in people's lives. Hatches, matches, dispatches, important life events, relationships breaking up, deaths in the family, and so on. Bear in mind that we're talking about housing and health, and other people have got other things to think about. I'm not going to dwell on this, but these are examples of things. There are things we can do to tackle inequalities, and housing is in there, sort of midway down. But also, to read out the main point under the individual experiences, we should link public services for vulnerable high-risk individuals. We can do that, we should do that. We know there are results, we know we can narrow inequalities that way. So here's my last slide. If we want to achieve a fairer, healthier Scotland, we, in broad terms, know what we need to do. There are things we can do and the things we should avoid. We need action in several levels. Housing is a basic requirement for health. Shelter, security. I'm sure you all agree with that. It is a sentinel issue for inequalities reflected in poverty and deprivation, because your house says a lot about your place in life. But housing is usually not the only problem. There's poverty, there's low income, there's many dimensions of poor well-being and low income. Poor housing and health go hand in hand. The evidence is accumulating. What comes first is worth study, but it's clear that poor housing makes a bad situation worse. Homelessness is many degrees worse than that. Risks and poor outcomes climb steeply. There are overlaps with other social determinants, such as disability and offending, as I've illustrated, but there are so many other dimensions. So the solutions, no single measure, several simultaneously, look upstream to crisis, from crisis to what causes people to be in trouble, to have a poor expectation of lives. The solutions may be multiple, but they are joint and person-centred. They have to be, and we have to be different about that. The entry points to support are just as many as the problems for which the service exists. I'm thinking of offenders, I'm thinking of people with disability who come into these services, and that should be a channel to other things. Legislation is a great achievement. It's a political, symbolic, and also deeply practical measure, but we need to implement these measures, these helps. And Graham's action plan on behalf of Shelter offers us some hooks for that. And our action plan, our strategy on tackling health inequalities, is fully in concert with that. I'll end there. Sorry I've overrun your time slightly, but thank you very much.